Well, I'm glad you're here, and I want to introduce everybody to Rebecca, who's going to get us kicked off. So,
all right. So, hello. Thank you for coming. It's really nice to see folks that I've actually spoken with before, and you're here in person, and so that's really lovely, and it's really nice to see everyone. I'm waving to the screen. I don't know if that really comes through, but it's really nice to see everybody that was able to join us remotely as well. So my name is Rebecca Edwards. I'm from the Easthampton Healthy Youth Coalition out of the Easthampton Health Department, and we are working on teen substance use prevention. We work with the entire community toward that goal, and in particular with parents and young people as well. So tonight we are collaborating on this event. We are very, very happy to be in this beautiful space here at Learn to Cope with Peter and with Wendy from Hampshire Hope. And thank you to Easthampton Media for recording this so that people can see it if they weren't able to attend at this current moment. This is a really important topic in general and right now. We are going to have training on how to use Narcan and also talk about fentanyl and the dangers today that fentanyl is presenting. So with that, I will turn it over to Peter. Or to Wendy.
Yes, thanks Peter for starting up the slides. I think the first two slides were just kind of like our opening slide. So while you're looking at that, I'll say my name is Wendy Penner, and I work for the City of Northampton Department of Health and Human Services, and we have a division that does work related to substance use. And the work that I do mostly is related to our DART program, which is Drug Addiction Recovery Teams. And I'll talk about that a little bit more perhaps later. But we also have a county-wide coalition, and this is the website for that, called Hampshire Hope. And you can find it on the internet at hampshirehope.org. There's a lot of information and resources there. And I'll speak a little bit more about the range of things that the Hampshire Hope Coalition does. And then we also have a youth substance use prevention or primary prevention coalition under our umbrella called the Northampton Prevention Coalition that is similar to the Easthampton Healthy Youth Coalition. I'm just really happy to be here tonight to be able to talk to you about opioid overdose awareness and youth, because it is an important topic. It falls under the umbrella of youth substance use prevention. But we're seeing some concerning new trends, and I think it's important to put those in context when we think about the concerns related to youth substance use and experimentation. So Peter, if you could go to to the next slide, and then I'm going to have you go back to this one. So I want to start off by talking a little bit about this is a sensitive topic that we're talking about. People who may have a substance use disorder, an opioid use disorder, may have addiction, and that that can be a chronic disease, and like other chronic diseases, it has a lot of different components to it. There's a genetic predisposition, there's a behavioral component, and there's a physiological component, something that happens in the brain from repeatedly using substances. And so this is a public health concern. And one thing that can be really hard for people who have experience in their families around addiction is sometimes people are not super thoughtful and careful about how they use their language to talk about addiction. They might say that people with addiction are addicts, they're junkies, they're doing something illegal, they're criminals. And that can be very hurtful, and it's also can feel like really lacking in compassion. And so it's important that even though to us the behaviors and the choices of people who are using substances, misusing substances, who have addiction might not make sense to us, they might seem selfish, they might seem just really harmful and stupid, and why don't they just stop? It's important to remember that we don't always know other people's personal experience with substance use disorder, whether that's the person with the substance use disorder or a family member, and even regardless of what your own personal beliefs are, to just try and have that compassion and hold that space for other people around what their lived experience might be. And this also can bring up feelings of concerns for how does this impact me? What does this mean for me and for my family and my loved ones? And that, those can be hard feelings. And to just make sure that you create space to, take care of yourself. And, sometimes maybe these are conversations people need to maybe take a step away from for a day or a period of time or a few minutes. And it's okay to do that and to take care of yourself. And, my colleague Sherry Sullivan developed these slides, and I really like this point that, people are often doing the best they can do with the knowledge or experiences that they've had. And, I think when we think about young people, we think, well, kids just need to know, like, they need to just say no. And, to really just try and take a minute to go back to what it's like to be a youth, and especially young people right now. We know that they're facing sometimes overwhelming challenges related to their mental health, and just getting out of bed and going to school can be, really hard. And we might feel like, why would our kids ever do things that could put them in harm's way, whether that's experimenting with alcohol or vaping or hanging around with people who might be doing activities that we don't think are healthy for them to be around, or having sex or whatever it is. But those behaviors make sense to them. They're getting something from those behaviors. And it's important to know that and to think about that and to want to connect with people with that awareness. And that there's really a way for all of us to be part of the solution of addressing this public health problem of addiction. It can be hard, especially with some of these challenges in the drug supply that we're going to be talking about tonight. But there are a lot of really wonderful, thoughtful people doing great work, and we're a community. We're here in this beautiful community space tonight, which I think is a great example about that. And just before I go back to talking about our goals for tonight, if you think about a time when someone who you loved or cared about had a loved one who was sick, maybe they got a cancer diagnosis, and how do people respond to that? They really they want to gather around that person. What can I do? How can I help you? How can I support you? And if you think about a time when you found out that someone was being personally impacted by addiction, their own or a loved one's, you might not feel comfortable doing that. And the joke or the saying is always like, no one brings around a casserole when your loved one has addiction, but they do when you have cancer. And so I think that's just something to think about, and to think about how we can really be present with these challenging conversations and just keep our minds as open as possible. So that's just kind of like the foundation. And if you don't mind going back to the previous slide, in terms of what I'm going to talk about is what is the work taking place to address addiction, review the basics of the physiology of addiction, and we're going to watch a short video actually about that's going to do the work for me, and then talk about some trends related to the drug supply and the risk for overdose among youth, and then hand it over to Peter for the rest of the time to talk about naloxone, which is really this miraculous overdose reversal drug, and how we can use it. And he'll speak a little bit more about the drug supply and what an opioid is, etc. So any questions from anyone before I move forward? Okay. So in terms of the work taking place around addiction, I've mentioned some of it, but I just want to talk about, there's this concept of the continuum of care. So there's prevention. Here's some pictures of some of the work that we've done with our coalition. So there's that prevention, that youth substance use prevention, supporting kids' health and wellness, helping them understand that their brains are still developing and the risks of using substances, and that awareness that alcohol and tobacco, or alcohol and nicotine, with vaping, it's not so much tobacco, are typically the substances of first use for young people. It's not opioids or fentanyl or pills typically at all. But that early use of substances puts them at a greater risk for developing addiction. So there's prevention, there's intervention. So that might be, do people need some intervention because they're doing some risky behaviors? Do they need some counseling, some guidance, some direction to services? And then there's treatment. If you have a substance use disorder, what is the pathway that's going to support you around reducing the harm as a result of your addiction and having the option that works for you around recovery? And there's a lot of different recovery pathways. There's 12-step recovery, there's recovering on your own, there's a faith path, there's a lot of different methods of treating people and of supporting. So there's treatment, and then there's recovery. And that's where community comes in, because recovery for a lot of people is a lifelong journey. It's about your overall wellness, not just abstaining from substance use. And that's why we're really lucky we have resources like the Recovery Center, the Northampton Recovery Center. And then overlaid onto all of that is this thing called harm reduction, which is if people are going to use drugs, how can we make sure they're doing them in a way that's as safe as possible? And so like when you get into your car and you put on a seatbelt, that's harm reduction, right? Or when you go into a bar and they say, you're not allowed to serve someone who's intoxicated, that's harm reduction. And so we have organizations like Tapestry that say, hey, if you're gonna use drugs, we want to make sure you're using clean needles. We want to make sure you have Narcan. We want to make sure that you have sterile supplies. And that you can get treated if you have infections or diseases that could make you sick. So that's sort of the continuum of care around people who are impacted by substance use that's helpful to think about. And and another part of our work is honoring and helping people with grief and loss and bereavement related to addiction. So you see here a wall of remembrance from one of our events in the region. So could you go to the next slide? This is again from one of the vigils of remembrance for people who lost to overdose. Okay, so I think I actually covered a lot of this. I forgot that this slide is in here. So the Northampton Health Department brings people together. We have overdose response teams. We bring together providers to look at what are the gaps in the continuum services, providing Narcan. I mentioned Tapestry, the syringe access and harm reduction program. I work on the DART program, the drug addiction and recovery teams. And we have regional recovery centers in Hampshire County and Northampton and Ware. We have the district attorney's drug diversion to treatment program, and we have nalox boxes that contain naloxone that can be posted in public buildings. They have one right here at Learn to Cope, as well as sharps boxes to dispose of used needles. We collaborate with the business community, and we promote harm reduction throughout all of our work. So harm reduction is a set of practical strategies to reduce the negative consequences of drug use, but also a movement for social justice, built on a belief in and respect for the rights of people who use drugs. So that's a lot, and maybe we'll come back to some of it later, but let's go back to, for this topic tonight about youth and substance use, what is addiction? And we're gonna watch a short video about the developing brain and addiction that I think is really helpful for this topic. Might take us a moment to cue it up. We're working on it.
Wish you work the sound.
What is addiction? It's also called a substance use disorder. Over 20 million people nationwide suffer from addiction. 1 in 7 people will experience addiction at some point in their life. Scientists first began to understand addiction as a brain disorder back in the 1950s. Doctors Olds and Milner, in laboratory studies of rats, found the parts of the brain affected by addiction. But then in 1994, Doctors Volkoff and Shelberg, top neuroscientists, ran PET scans of the brain that showed the effects of substance use disorders. And like other diseases, these scans showed it affected tissue function. So there are two main parts of the brain affected by drug use: the limbic system and the cortex. The limbic system, located deep within the brain, is responsible for our basic survival instincts. So when you do essential things to stay alive, like eat, drink, find shelter, build relationships, or care for your young, your brain reinforces behaviors that cause the release of dopamine from this region. That reward for surviving is also transmitted to the amygdala and hippocampus, which records a memory of that feeling, so we seek it again. This is our survival hardwiring. Addiction also affects this area, up here. That's the prefrontal cortex, which is what separates us from other animals. And this is where decision-making and impulse control live. When drugs or alcohol are used, they activate the very same dopamine process in the survival center. And when use is repeated, that substance can hijack that part of the brain. This hijacker changes the brain and weakens this system to make it believe that the primary need for survival is the drug. In hijacking the brain, it can usurp those primary motivations: food, water, shelter, relationships, and protecting our young. And the hijacker needs more and more of the substance to activate the same level of reward or feeling of pleasure, causing the brain tissue to become increasingly damaged with continued drug use. So why don't all people who use alcohol or drugs become addicted? There are factors that contribute to the development of a substance use disorder. They include individual factors like your genes, your age of exposure, and then environmental factors like drug availability. But there is good news. Addiction is preventable. Key factors that aid in preventing addiction can be categorized into two parts: risk factors and protective factors. Protective factors range from parental involvement, programs that improve self-control, limiting availability, and increasing attachment to your community. Another key element in preventing substance use disorders is to delay when use begins. Put simply, prevention is about delaying the onset of first use. In the adolescent brain, where brain tissue is more vulnerable, the hijacker is more prone to weaken the brain and plant itself as a disease. Those with substance use disorders commonly initiate first use much earlier, between 12 and 18 years old, which increases the likelihood of the hijacker taking hold. But if the hijacker does take hold, addiction is treatable. Advancements have been made in assessments, treatment programs, recovery supports, and medications to treat addiction. Brain scans show that once in recovery, the tissue in the limbic system and cortex can get better. With your help, we can expand these innovations to help millions of individuals and families and ensure that addiction is treated as the medical issue that it is. Together, we can solve this. Join us.
Thank you. So that's a good, I think, introduction and overview of the physiology of addiction and like this idea of the broken brain. And a lot of times once people are addicted to drugs, they're not using them to feel good, they're just using them to not feel bad. And this is especially true with opioids. So today we're focusing on fentanyl because what we are seeing is that the opioid epidemic, which began as a result of the over-prescribing of prescription opioids, if you look at this blue line that's shooting straight up, that all represents the synthetic drugs, primarily fentanyl, that are driving the overdose deaths in our country. And so our drug supply, our illicit drug supply, is contaminated with fentanyl, and that problem has been growing. And so even though we see a lot of great treatment programs, a lot of great prevention programs, a lot of interventions and growing harm reduction programs, we're unfortunately seeing those death rates continue to increase. And of course, the isolation and other factors, trauma of our global pandemic hasn't helped either. So not only are opioids contaminated with fentanyl, but other drugs are as well. And this is concerning, for our young people who might be experimenting and might be buying what they think are prescription drugs on the illicit market, but it turns out that it's not really a prescription drug. It's a pressed pill, it's a counterfeit pill that might contain fatal amounts of fentanyl. So when we talk about the changes in the youth overdose risk, we are seeing that overdoses are now the leading cause of preventable death among young people aged 18 to 45, ahead of suicide, traffic accidents, and gun violence, according to federal data. And although experimental drug use by teenagers in the United States has been dropping since 2010, so alcohol use, cigarette use, even cannabis use, a lot of these numbers have been trending downwards. The deaths from fentanyl have skyrocketed. And while the numbers overall are somewhat small, 884 deaths nationally in 2021 from 253 in 2019, it is a significant increase. And of course, it's an irreversible outcome. We're talking about not just overdose here, but death from overdose. So as I mentioned, the supplies of counterfeit pills that are tainted with fentanyl and other drugs are driving this increase. So we're here tonight because talking to your children and being a good source of information for them is important. And it's important to not just focus on, the fentanyl and opioids, but their overall, risk related to early use of substances of all kinds. But having Narcan and knowing how to use it can be a great vehicle to start and have a conversation. And that's where I'm going to hand it over to Peter. Thank you so much.
Thank you, Wendy. First of all, I want to welcome everybody who's here in person. It's great to have you here in our new center. This is Learn to Cope West, the first brick and mortar center within our network called Learn to Cope. And my name is Peter. I'm going to be speaking to you about actually using Narcan and what that's all about. I can tell you that I'm a person in long-term recovery. I'm also the dad of a young man affected by substance use, and I'm also a member of Learn to Cope, a place where I've found people who understood, and I didn't have to worry about stigma. I didn't have to worry about judgment, because this isn't about a failure as a parent. This isn't about a failure as a person in general. Substance use disorder is something that affects a great many of the people in our lives. So finding ways to deal with that in a healthy and wholesome and loving way is so very important. I'm going to be speaking to you, as I said, about overdose prevention. Learn to Cope is the first family organization that is part of the Department of Public Health's Overdose Education and Narcan Distribution Program. And right here at the center, we do distribute Narcan. We do the trainings and we distribute Narcan. So if you're tuning in from Zoom land and you're local, please feel free to come in and speak to Kathy, Magda, or myself, and we'll get you going with Narcan. And if in all of our meetings we provide Narcan, all of our regional managers can help you with that. So by all means, feel free to reach out to us. So let's talk specifically about opioids and naloxone. So when we talk about opioids is an umbrella term for a great many medications and drugs that either have their organic base in the opium poppy or are synthetic forms of that, or semi-synthetic forms. And so we're talking about prescription opioids like oxycodone, Oxycontin, Percocet, Vicodin, etc. Or we're talking about street drugs. So drugs like heroin and illicitly manufactured fentanyl. There's two different types of fentanyl. There's the prescription fentanyl, and then the IMF, the illicitly manufactured fentanyl. And when we talk about fentanyl, then there's a whole family of analog drugs. Those are chemicals that have a similar molecular structure and do similar things, but the ever-growing array of those drugs is just terrifying. And then there's medications for opioid treatment. There's approved by the government, by the FDA, there's 3 medications. 2 of them are opioid agonists, which means they satisfy the same parts of the brain that the opioids do. There's methadone. Most people have heard of methadone at this point. That's a full agonist. There's Suboxone, buprenorphine, which is a partial agonist. And then there's an antagonist medication called Vivitrol, naltrexone, which blocks the effects of opioids. In terms of prescription opioids, this is a particularly dangerous topic because a lot of the medications that people might think that they're purchasing on the street, a really popular drug on the street for a long time was what was called Perc 30s, and this is a 30 milligram Percocet. It's really oxycodone. Percocet is typically oxycodone and Tylenol. Perc 30s just 30 milligrams of oxycodone. And then Percocets on the street, Vicodin, Dilaudid, fentanyl. What we're finding, when I say fentanyl, in this case, what I'm talking about is the prescription fentanyl. What we're finding is that there's basically none of these drugs on the street right now. All of the drugs that people think they're buying that are prescription medications are primarily counterfeit. These are drugs that people have pressed using a binder and using fentanyl as the chief active ingredient in them. And there's ways to check for this. Fentanyl test strips are available. In fact, Hampshire Hope provides fentanyl test strips. Tapestry provides fentanyl test strips, and this is something that can help people figure out if there's fentanyl in the drug that they're taking. Something I found very interesting is they find that when people know that what they're taking contains fentanyl, 65% of the time, they'll choose a different behavior. That doesn't mean that they won't do it. However, they might do less. They might do it slower. They might make sure that somebody's around them. They might take turns who's going to use first. Of course, a lot of us would prefer that somebody just doesn't use at all, but the reality is people are going to use. So if they have a safer way to protect themselves, we're that much more ahead of the game. Sometimes people can inspect the texture and the color and the smell of the pill if they know it well enough. But let's face it, when we're talking about adolescents, they don't know those things, right? They don't know the difference between one and the other. And Wendy was talking earlier about the increase in adolescent deaths because of overdose. We're not talking about people who are long-term addicts. I hate to use that word. We're not talking about people who have a long-term history of substance use disorder. We're talking about people who are experimenting, and because of the counterfeit drugs on the street, it's so much more dangerous than it ever has been. Because fentanyl has a much stronger effect than other opioids. It's about 50 times stronger than heroin, and we know that there's basically no heroin on the street anymore. Most of what people are buying thinking it's heroin is really fentanyl, and it takes just a few grains of fentanyl for somebody to find a fatal reaction to. So when people are in harm reduction are talking to people who do use drugs, they encourage them to, as they say, start low and go slow, to just do a little bit at a time. Especially if they're changing dealers, if they're changing their supply, and it's really important that people aren't alone when they're using. That's one of the greatest risk factors for fatal overdose, when nobody's there to see what's happening. So it's really important that people find a way to use where it's safer if they're going to use. The thing about fentanyl is, while it's kind of snuck into the drug supply, prior to 2013, we really didn't see it much at all. When we did, it was pharmaceutical fentanyl in the form of pills or transmucosal strips that people they on the street, we called them fentanyl pops, or patches that people would scrape the chemical off of and then smoke it and what have you. But now what we're seeing is the illicit fentanyl. And while some people avoid it, there's some people now that seek it because of the strength. The thing about this, it's got a much shorter half-life, which means a much shorter time that it has an effect on somebody. So if somebody was using a chemical like heroin, they would need to re-inject or re-administer that drug every 6 or 8 hours. With fentanyl, because it's so short-lived, they have to re-administer every 2 hours or so. So it means they're using that much more often. With most opioids, there's kind of a rush that happens versus legs, where it takes more and more time. With fentanyl, it's a really quick rush. And one of the things that I really want to, I'm not going to read this whole slide to you, but one of the things that I really want to point out is, besides the rapid onset, there can be seizure symptoms with the use of fentanyl. Specifically something called wooden chest, where the muscles of the chest seize up. And when we start talking about reviving somebody, one of the things that we want to talk about is doing chest compressions. But when somebody's chest is fully seized, it's nearly impossible to do those chest compressions. So trying to rescue somebody becomes that much more difficult. When somebody takes a fatal amount of an opioid, what happens is it's just more than their body can handle, and it affects the parts of the brain that are responsible for autonomic function. So it gets to the point where it's depressed that part of the brain so much that their breathing stops, that they no longer breathe, and they become unresponsive. In terms of how long it takes, it depends. It can take hours, or it can take just moments. And with fentanyl, that's the biggest challenge, is it's really quick acting, and overdose can take just seconds before somebody is in really trouble. The biggest point with determining if somebody's overdosing is that lack of breathing and the unresponsiveness. Okay, lack of breathing and unresponsiveness. I want to draw attention to the fact that we do have somebody who's I was going to say manning. Would we call it that, Magda? Magda is taking care of the Zoom folks. So if you have a question, make sure to let Magda know, and we can answer that. Okay. So let's talk about naloxone. Most people call naloxone Narcan. Narcan is a brand name. And the one and only thing that naloxone does is it's an antidote to opiate overdose. That's the only thing it does. It's not harmful if somebody uses it and they're not having an overdose. It just does that one and only thing. And what it does is it blocks the opioid receptors and gives a temporary reprieve. Temporary. I need to stress that. It's not like you do this medicine and you're all set. It's temporary. Typically it takes 2 to 5 minutes. Let's just call it in the middle at 3 minutes. Typically it takes about 3 minutes, and it's got a half-life between 30 and 90 minutes. So let's call that 45 minutes, okay? So for about 45 minutes, a person is relatively safe if they're revived. There's different types of naloxone. I'm not going to go through all of that. The one that we're going to focus on is this one here, B in that picture. It's nasal naloxone, and it's the one that's provided by the Department of Public Health. It's the one that we provide here. It's the one that Hampshire Hope provides, and most people who are providing Narcan, this is the one that's provided. So the way that it works is that when somebody's using an opioid, that opioid sits on what are called the mu receptor sites. It sits on the receptor on the brain, and that's when it starts having that effect, where it's depressing the centers of the brain. When somebody uses Narcan, what it does is it kind of knocks that opioid off of the receptor. This is Wendy's favorite slide. We spray the Narcan inside somebody's nasal cavity. It's absorbed through the mucous membrane. It goes to the brain, and it knocks the opioid off of there. So for the next, let's call it 45 minutes, 30 to 90 minutes, for the next 45 minutes, it sits on that opioid receptor, so somebody isn't having the effect of the opioid, and it restores breathing. That's the point I really want you to remember. It restores breathing. There was a time in the past when people were using heroin and somebody would get a dose of Narcan and they would sit up and they would have different responses, but people actually called it the Lazarus drug for a while. We don't necessarily see that as much anymore, and it's okay. What we want is just to get somebody breathing again. Then EMTs will take care from there. We just want somebody to breathe and live. Does that make sense to people? Okay. There's a lot of myths about naloxone use. Without going into the myths, I want to tell you what naloxone isn't. It doesn't make people violent. They did a study of over 12,000 cases, and they found in 1% of the cases that people had really strong reaction. 1%. People do not become tolerant to naloxone. I've heard first responders in the early days of naloxone use who say, well, you know, I've already Narcan this person 4 times. It's not even going to work on them anymore. Not true. Okay? People do not become tolerant. People don't get high on naloxone. The only thing it does is it takes away the opioid high. And naloxone only reverses effects from opioids. Now this is important because what we're finding is a lot of people mix drugs. So if somebody was using an opioid and a benzodiazepine and they were overdosing, it wouldn't reverse the effects of the benzodiazepine. It would only reverse the effect of the opioid. That might be enough in that case. But it only reverses the effects of opioid. So I mentioned earlier the length of time, the half-life of different opioid drugs. And so this slide shows both the half-life as well as the potency. And so if we look at methadone, really long-acting opioid, and that's why it can be an effective medication because it lasts for 16 to 32 hours. It's moderately strong. So it appeases the craving. It appeases the withdrawal. Heroin 6 to 8 hours, oxycodone 3 to 6. But now if we go down to fentanyl, up to 2 to 4 hours, sometimes not even that long. And it's the strongest, not counting the other analogs, it's the strongest of the opioids. So it's got a short half-life, so somebody needs to keep doing it. It hits really quick, and it's extremely strong. Now, once again, if somebody's using opioids, they find themselves in a situation, or we find them in a situation where it's a fatal dose, that 30 to 90 minutes that the Narcan is working, that other opioid is still sitting in the brain. When the fentanyl reaches its half-life, that fatal dose might still be in their system, and they're in danger of going back. So it becomes really, really important, and I'll talk about it again. It becomes really important to call 911 to get somebody the help they need. There's a lot of risks for opioid use. Including, you know, if somebody goes from one product to another, and that's really typical on the street. What's on the street today is not necessarily what's on the street 2 hours from now. It might have the same markings on the packages, but it might not be the same product at all. If somebody has a previous history of overdose, they're more likely to overdose again. If somebody has a long history of addiction, they're more likely. Here's one that's scary and confusing to a lot of people. One of the greatest risk factors is abstinence. If somebody's been in a program, whether it's detox or in a treatment recovery program, or if they're in an abstinence-based program like AA or NA or something like that, so they're not using for a period of time and they return to use, their tolerance of any opioid is eliminated. And so when they use the smallest amount, they're at much more risk. If people have other chronic medical illnesses or mental illnesses, they're much more likely to be at risk. Social isolation, and Wendy mentioned this before, especially in the last 2 years. Social isolation is a huge problem. People are alone, feeling alone before they use, using alone, etc., and then mixing different drugs, polypharmacy. People mix different drugs. It has synergistic effects. It drives each drug drives the effect of the other up. It multiplies the effect rather than just adding to the effect. So all of these are risks for an overdose. But then we need to add this one, the contaminated drug supply. The drug supply on the street is poisonous. You know, and I hate to be dramatic, but it's the reality. There's very few drugs on the street that are not contaminated with fentanyl these days, including drugs that you would never expect, like cocaine, methamphetamine, and Adderall. So people who use those drugs are also very susceptible to overdose from, and even more so because they'd have no idea that the stimulant drug they're using is going to have an opioid in it and cause them to be at risk. So it's really important that we speak to people who, we know that the use of Adderall is really popular with school-aged people. So it's really important that we reach out to them and let them know this information, that we provide the education that's going to help them. And very often we suggest that people who use stimulants, that they get fentanyl test strips too, and check to find out whether or not their product has that in it. So if we find somebody who's in an overdose, and I'll talk about what that looks like in a moment, these are the steps that we want to use. First of all, recognize the overdose. And then secondly, call 911. That is so very important that we call 911, that we get the professionals there as soon as possible. As soon as we call 911, we're either going to administer the naloxone or provide rescuer protocols. I'll talk about those in a moment. And then stay until help arrives. That's really important. A lot of times people who are using with somebody else, when somebody, as we used to call it, rolls out because of an overdose, people are afraid to call the police. They're afraid to be there when first responders show up. But it's so important that we're there with the person until breathing resumes and or help arrives. So here's how we can recognize an overdose. First of all, let's talk about what it's like to be really high on an opioid. So a person gets really relaxed, their speech becomes slowed and slurred. Oftentimes they look really sleepy. The folks that come to our meetings often say that they can tell when their loved one is using just by the way they stand, just by the way they look. They don't have to speak to them or anything else. We can tell by the posture. People do what we call nodding, where they're starting to fall asleep and their head's dropping, or it seems like their neck and head are defying gravity. They're just really falling over. But here's the thing: in most cases, when somebody's really high, they will respond to stimulation. If we yell their name, if we do a sternal rub. So a sternal rub means you take the tips of your knuckles in a really sharp fist and rub it on somebody's sternum. Okay, it hurts. Here in Massachusetts, it's not unusual for us to have 18 layers of clothing, 12 months a year, so it's hard to get to the sternum, but you can do the same thing underneath the nose, at the nostrum area, and once again rub it, and it's going to cause some discomfort, pain. But what we're trying to do is get somebody to respond. Pinching, anything like that, to try to get somebody to respond, because that's an enormous piece. Overdose looks different. Again, autonomic functions are reduced or eliminated, so if they're breathing at all, it tends to be a really deep snoring or gurgling. I liken it to sleep apnea, where somebody stops breathing and then they go into agonal breathing. Their body is trying, and it's agonizing to take a breath. I guarantee if you hear it once, you'll never forget that sound. I hope you never do. Very infrequent breathing or no breathing at all. The skin becomes very pale, gets clammy. The person goes into a nod, but this time it's a really, really heavy nod. They may seem like they're asleep. They may seem like they're unconscious, but they're not responsive to stimulation. That's the most important part. Also, at this point, if I'm not breathing, my heartbeat's going to slow down. My pulse is going to slow down. I don't want you to take time to take somebody's pulse. I don't want you to listen for their heart. The two things I want you to do are to pay attention to breathing and responsiveness or lack thereof. Does that make sense? So, if somebody's really high, as painful as it might be if it's your loved one to do so, we want to try to stimulate them and observe them, watch them. Peter, are you okay? Are you okay? Okay, just watch now to find out. Because somebody can be really high and then slip into overdose. So we want to observe. Once they're no longer responding, call 911, give the naloxone, do rescue breaths or CPR, and chest compressions. Okay? Questions about any of that? Questions in the room about it? How about in Zoomistan? Any questions?
So there's a question or comment on Zoom from Ruth talking about she knows young college student who took Xanax was not addicted to drugs or using fentanyl, but a Xanax that was laced with it, and she died in her sleep. And asking us to talk about parents, how parents can talk to their children or teenagers about this kind of risk.
Okay. So to the first point, that's exactly what Wendy and I were talking about, the counterfeit medications that are on the street. Xanax is one of the most popular ones. It's really cheap. It's easy to get. Xanax used to be cheap and easy to get, but now with the counterfeit, it's cheap, it's easy to get, and kids don't know. One of the things, in fact, a friend of Wendy and I, the other night was talking about this. People will take a pill orally and then not feel anything, because the way fentanyl works, it doesn't metabolize well in the stomach, so there's not much of an effect. And because they took this and it didn't really do anything, it's not unusual for somebody to say, well, let's crush it up, let's do a line. And they'll crush it up and they'll insufflate it or snort it, and then they wind up having the fatal effects. And it stimulates what was in the belly, and that gets into the bloodstream. So I'm very sorry for the person who reported that, but unfortunately it's not that uncommon. In terms of how do we talk about it, I think we'll probably get to that. But the most important thing about that is honestly. That's how we talk about it, honestly. Without anger, without yelling and screaming. I've tried all that stuff, yelling, screaming, threatening, punishing. I tried all of that. None of it worked. The only thing that works is actual communication. Did that answer the questions, Magda?
Well, she says no, but what do you recommend how friends can keep each other safe? So I think we're going to have more conversations about that after your presentation, so I would say,
Awesome.
hold tight, we'll get there.
And just to reinforce, Peter, like the point that you made about not using alone.
Mm-hmm.
Like that is the only reason someone dies of an opioid overdose is because they used alone.
Exactly
so
right.
I think that's one thing that can be part of the conversation, but I know that Rebecca and Ann will talk more about how to talk to young people.
Thank you. So once again, this is talking about the stimulation. I've already spoken about that. It's really important to try to stimulate somebody, calling their name, tapping on their chest and arms, all that stuff. And here's something that's relatively new phenomena. What they find is that before giving the Narcan, that we actually verbalize, that we actually say, I'm about to give you Narcan. And for some reason, well, one of the reasons is people don't want to be Narcaned. Okay, there's it's not going to be comfortable, but for some reason it reaches in when other things happen and people have really responded. So letting somebody know before we actually give them the Narcan, we tell them I'm going to give you Narcan, and it's been very effective with people. I already spoke about the 911 call, how important that is. And I also spoke about people's fear about calling 911. Well, there's something here in Massachusetts. Most states now have a Good Samaritan Law. But the Good Samaritan Law is there to protect people that call when they're responding to an overdose. The idea behind that is if the police show up, they're to treat that as a medical emergency only. They're just supposed to be, that they're not there to do a criminal investigation. They're not there to arrest somebody. They're there to assist in a medical emergency. However, there are cases due to if they arrive and there's a large quantity of the drug, there's weight. If they arrive and they recognize people in the room with active warrants, if they arrive and they see weapons, or if there's children in the room, then they have an obligation to respond as law enforcement officers. But if those conditions aren't there, then they're there just to assist. So this tells you how to administer naloxone. So here's my naloxone. It's in a foil pack. I peel back the foil. I take out the directions. I take out the Narcan. Place it in the nose. Now, oftentimes people say, well, if they're not breathing, how can they inhale the Narcan? They don't need to inhale the Narcan. It's not an inhalant. It's a nasal spray, because what happens is it's absorbed in the mucous membranes. It goes from the mucous membranes to the brain, and it works that way. You put it in the nose. You don't prime it or anything first. You put it in the nose, and then you spray it. It's that easy. So that's one dose, okay? When you get Narcan from us or Tapestry or Hampshire Hope, what we will provide is a box with 2 doses. If you give it and you wait the 3 minutes and the person hasn't begun breathing, then you use the other dose in the other nostril. Questions about that? No? Okay. I wonder how many people in this room have been trained in rescue breathing. Anybody? Oh, good. Good. Most of the room. And I think these days that most of us at some point have been trained in rescue breathing. Rescue breathing for overdose rescue is the same as it is for anything else. You don't do a finger sweep or anything like that, but you tilt the head back, you look in the mouth, make sure there's nothing in there, lift the chin, pinch the nose, put your mouth firmly over the other person's mouth, and give a breath every 5 seconds. So what we're going to ask you to do in this case would be to give two breaths, give the Narcan, okay? And then give continue to do that every 5 seconds, continue to do the breathing every 5 seconds, and give a dose of naloxone every 3 minutes if necessary. Hopefully, before you've given your second dose, EMTs have arrived. If not, give the second dose. And chances are, if you've gone to the entities I've spoken of, Hampshire Hope, Tapestry, or Learn to Cope, we're probably going to give you 4 doses just to make sure that you have it. I'm not going to talk a whole lot about chest compressions. If you haven't been trained in chest compressions, it's not a great idea to try to do it. What I would suggest is perhaps going onto YouTube and watching the videos. There's many of them on there. Taking a first aid course in which they'll train you on that or something similar. But learning how to do that, because it's not just about overdose. It's anybody who's unresponsive. You might need to perform CPR and chest compressions. One of the things about COVID and overdose is that if we're doing if we're rescuing somebody, there is a good chance that if either one of us have COVID, that we could very easily aerosolize the virus and one or the other become affected by it. If it's somebody in my household, I'm already exposed, right? So I'm not worrying about that. If it's somebody on the street, everybody's got to make the choice that makes sense for them. First responders are going to have gowns and all that stuff, and it's important that we do protect ourselves, but really it comes down to responding to somebody who's losing their life. If we're doing CPR, you can't wear a surgical mask. You can't wear your N95 and try to give somebody mouth to mouth. There are masks that are available. There are the face shields, the pocket masks, there's ambu bags and what have you, but for most of us, it's going to be direct contact with somebody that we already know. After we give them the medication, as I said, we want to monitor to make sure that somebody's continues to do well. Okay, again, they might just breathe, and that's awesome. But they're also at a very high risk period. So we want to make sure that they try to dissuade them from using again, and in most cases they're going to want to use again, and watch them in case the naloxone wears out. I already spoke about all of that stuff. If you do rescue somebody and they begin breathing, we want to put them in what's called the rescue position. And you can see it here. Somebody's on their back, we want to turn them on their side, one arm down, other arm across, one leg bent, and turn them on their side just so that they don't choke to death, okay? If the person comes to, very often, so what we've done is we've interfered in their opioid use. So they're going to have some discomfort. Very often they get headaches. Oftentimes they feel embarrassed. Oftentimes they feel confused, disoriented. Very often they want to use again. I can speak for myself. When I came out of an overdose, I had no idea that I had overdosed. All I know is that I wasn't high anymore, and I wanted to use again. And I'm not an enigma. That's really common. If we're with somebody that's revived, we want to try to reassure them that I know you're not feeling well. When they get here, they're going to help you feel a lot better, and encourage them to stay and stick around for the medical attention. Some of the things that they might feel are anxiety, severe anxiety, runny nose, chills and muscle aches, disorientation, nausea and vomiting and or diarrhea. Taking care of the naloxone, when we have it, it's light sensitive, but because of these containers, it's not affected by light. We want to store it at room temperature, although there's some new reports that are out within the last year or two that show that it really can take extremes of temperature and without breaking down for at least 28 days. But we still want to keep it in moderate room temperatures, avoid freezing, avoid excessive heat. On the package, both on the box as well as this foil, there's an expiration date. Keep watching that. Any of the people that I mentioned will distribute Narcan, will replace your Narcan. Anyways, we'll also tell you to keep what you have because it's good after the expiration date, but use the fresh first. And what I would really encourage you to do, if you have somebody in your life who does use drugs, have a conversation with the people that live in the house. How do you plan to protect somebody from overdose? Consider what is your plan if you witness an overdose. It's not uncommon these days to be in a public place, whether it's a public restroom or what have you, and encounter somebody that's in distress. And I say this all the time, but you never know when you're going to be called upon to be somebody's angel. It's my opinion that every adult in the United States should have Narcan. And anybody who legally can possess it should possess it and have it on them, know how to use it and be ready to use it. There's some, if you look for the Opioid Safety and Naloxone Network online, there's some great information on there. There's an organization called Never Use Alone, in which somebody can call when they're about to use, and somebody will be on the other end of the phone monitoring them, speaking to them, and if they stop responding, we'll get first responders there. So that's all I've got for you. In closing, for my part, I just want to welcome everybody once again here to the center in Easthampton at the Eastworks building. If you're on Zoom, come in and visit us. Come check us out, okay? Thanks, everybody. I appreciate you all. And now, over to Rebecca.
So I'm back, and this is Ann Talley, our outreach coordinator, Rebecca Edwards. We're from the Easthampton Healthy Youth Coalition. So thank you so much to Peter and Wendy. We're really, really grateful that they could bring their expertise here tonight. And we just want to reiterate and also speak to Ruth's question. We are working to prevent teen substance use, and that we have the message to parents. We want to talk to parents about how important it is to talk to your young people about substances, about substance use, about what they see in their environment, about how to make healthy choices. And research says that these conversations are important to have in small doses frequently. And you can start young. And I told a story about recently, I have very small children, and I was telling my 5-year-old that he shouldn't have candy before asking an adult if a friend were to give him a piece of candy, because sometimes candy has medicine in it. And we know that, that kids recently sometimes will find cannabis edibles that look like candy, and they will have very bad effects and end up in the emergency room because they have taken what they thought was candy because they're kids, and it actually has high doses of cannabis in it. So I need to speak with my kids already at this very young age about the fact that some candy has medicine in it, and they need to talk to an adult before they really put anything in their mouths. And so I'm starting to have those conversations now, and of course as they get older, those conversations will shift and change and evolve, but I never want to stop having those conversations. And as we're hearing tonight, this is so important because the landscape of substances is changing. And as Peter said, fentanyl was not really to be found in the illicit fentanyl until 2013, did you say? And here we are, and a large portion of the pills that people can find that are counterfeit, so not from a pharmacy, have fentanyl in them. And young people do experiment with things like Adderall or Xanax, young people that are trying to self-medicate. For example, in this very stressful time, stressed about school, stressed about life, we all know what it's like right now, and they're not looking for this, but they're not looking for an opioid necessarily, they're looking for a Xanax. And they don't have this information. So it's our job, all of us, all of the parents, and all of the young people that are hearing this that can inform their friends. We really, really need to get this information out. So whoever has heard this tonight, like, this is power for you. Knowledge is power, and then sharing that knowledge is sharing the power to protect yourself, to protect people that we love. So that's really the message, like, talk to your family, talk to your friends, have your friends talk to their family, please share this knowledge, because the numbers are going up for youth overdose, and it's very scary. And so again, the Easthampton Healthy Youth Coalition, we're focused on teen substance use prevention here in Easthampton. We work with coalitions throughout the county and other counties in Western Massachusetts. Do you want to add anything?
Yeah, I was just going to say that there's a great resource called Talk They Hear You, which is actually a website. It's part of SAMHSA, but you can also download an app, and you can almost just practice conversations you might have with your teens. If you're feeling a little uncomfortable about doing it, if you feel like you're not really sure how to do it, you can honestly use this app and talk to like a fake person, pretend how to do it before you actually do it. And one of the things they recommend the most is to talk to kids in the car, which seems really simple, but it's like you're not making eye contact, and you can't just get out and run away or say, oh my God, Mom, I don't want to talk right now. You're actually like driving them somewhere, and you're not looking at them in the eye, so it's kind of easier for the teens to listen in that setting. So it's something very simple, but it seems to be a really effective place to have a conversation. Mm-hmm. And like you said, talking about it a lot, talking about it more than once, not just one time, many times. And a lot of times teens seem like they're not listening. I used to be a middle school teacher, and they definitely did not listen, but they really are listening. You know, they don't think, it doesn't seem like they're listening, but they are. And they listen to the parents more than anyone else, and the data shows that. So just keep saying it over and over.
So the coalition, we have a parent group. We would love more parents to join us, and we want to be responsive to the needs of parents. So for example, if parents wanted to get in touch and say, we want to have a group to talk about the sport, to talk about strategies to talk to our young people, for parents to talk to each other, please get in touch with us. Also, we've thought about doing things like having a book club to talk about different strategies if we wanted to all read a book together. We're really open to ideas. We're going to have an event about vaping in the fall because that's a very big priority for people locally. My email address is redwardsma@easthampton.gov. So
easthamptonma.gov.
Say that again.
redwards@easthamptonma.gov. And I'm A Talley, same thing.
easthamptonma.gov. And maybe Magda, if you could put that in the chat, the right way, not the wrong way.
So maybe we can do that again?
Yes.
All right.
Red words, it looks like.
That's what a professor used to call me. Redwords at easthamptonma.gov.